So I have made it very simple. Which diseases we associate with GRD? So GRD is very common, whether we are a generalist, we are a specialist, we are a subspecialist, we are super specialist. GRD is with all of us. As doctors, as patients, as anybody and as everybody. And in Indian perspective, I think all of you must be having very annoying and very interesting anecdotes to share about GRD. So because gas goes to head, it can manifest in any form, any possible form, and our patients put it in the best possible way. But when it comes to science, yes, it has an association. It has an association with asthma. It has an association with interstitial lung disease. It has an association, it's a very common cause of chronic cough. It can cause chronic throat irritation. It can lead to COPD. It has an association with obstructive sleep apnea or obstructive sleep apnea syndrome. So it has an association, though how strong is the association or how exclusive is the association is still a matter of debate if we go by the existing evidence or guidelines. So we'll be talking about these diseases in respect of GERD. There is data. So maximum studies of this entity GERD, which is gastroesophageal reflux disease, maximum studies have been done in asthma patient and interstitial lung disease patients. So we have a robust data when we talk about GERD and lung manifestations. So if you go by the data, 77% of asthmatics complained of heartburn. And many of them associate their symptoms, 9 symptoms, to some symptoms which are related to GIT as well. They say that after having a heavy meal, the attack of asthma is there. So they associate the GIT symptoms with an acute asthmatic attack. So there is an association, and if we, So there is a very interesting study which was done on 1911 attack volunteers, patients, relatives. And a retrospective analysis was done on 37,000, more than 37,000 patients. They were anybody who were related to the attack, rescue workers, people around it, and it was done just like that. Out of interest, it was done because that was a cohort which could be studied, which were being studied for depression, which was being studied for respiratory illnesses. So it was a group which was studied, and it was found that nearly 20% people post 1911 attack suffered from GERD. And when this subset of this larger cohort was studied, patients who were asthmatics had higher chances of developing GERD. And as a chest physician, I would like to put it in the reverse gear. Probably they have GERD because they were asthmatics. That could be one perspective. We are talking about innovations. So in the era of innovations, any questions means how much absurd it may sound, but doesn't loses its significance. So yes, they said that asthmatics has more GERD, but I have another observation. Probably they were having GERD, so that was the asthma was more, or the other way round. So that is the graphical representation. So asthma alone, the GERD, the red bar is higher in asthmatics. So more GERD with asthma. And this is not a new thing. We know it since ages that people with asthma at times are uncontrolled. And as soon as you take care of their gastritis or acidity, they are better controlled. So that is a common fact all of us see in our day-to-day practice. So historically, pulmonary manifestation has been recognized as a potential consequence of GERD, and significant number of patients with asthma or chronic cough, particularly if it is nocturnal, GERD can be the culprit. So it's not a new thing, but it was re-emphasized into that cohort of people who were suffering from multiple things, maybe depression, maybe anxiety because of a loss of a dear one, or maybe that subgroup was very upset about the whole incident because they witnessed it. They were the rescue workers, they saw people crying into agony. So there are multiple factors, but one simple fact came out that asthmatics had more incidence of GRD. So, and as per the data, almost 30 to 80% of patients of asthma have symptoms suggested of reflux. So it's not a new thing, but then again, which came first? Is it the GRD or the asthma? So in my practice, when I deal with such patients, they might be the asthmatics, they might be patients. I never miss to take history suggestive of GRD. But then the problem is that GRDs not all the time come up with the typical symptoms. And Dr. Ajay Jain would be a better person to dwell on it. Sometimes it's silent GERD. And silent GERD, I don't know. But people can come up with very vague symptoms of simple heaviness, retrosternal heaviness, sometimes a throat irritation, sometimes postprandial heaviness. And the symptoms can go on and they vary from patient to patient. But still the question remains, it's the GRD causing the asthma or the steroids which we give for asthma causes the GRD? Because many patients who have severe asthma usually get 2 or 3 courses of steroids during a year's duration. And is that the steroids causing their side effects and causing GRD like symptoms, or it's the acid which is trickling into the lung which is precipitating the asthma? And this is the proposed mechanism, how the acid trickling into the lung airways can cause asthma like attack. So we had a reflux and the acid find its way into the airway by microaspiration and causes asthma. Second theory is that we have a similar embryological origin of the GI gut as well as the respiratory tract. So the vagal innervation which gets stimulated by the acid if it comes into the lower esophageal, distal esophagus or proximal esophagus, that stimulates the vagal nerve and can cause bronchoconstriction. So yes, we have science supporting the assumption or our hypothesis, yes, that acidity can lead to asthmatic attack. So does asthma trigger GERD? This is the proposed mechanism, as we have talked about. Coughing, it increases intra-abdominal pressures, increasing pressure gradient across the lower esophageal sphincter, which leads to GERD. And lower esophageal pressure also leads to GERD, and that could be because of asthma medication. So it's a vicious cycle. The medication leading to GERD and GERD leading to the microaspiration, but the strong association and clear-cut association is not yet well established. In a chest physician's point of view, when we should give more than normal importance of GRD? If anyway you're prescribing steroids, if anyway you're prescribing antibiotics, we prescribe an antacid. I know it can have its long-term side effect, but you know, in our practice, we tend to prescribe antacids without thinking much. Because we want our patient to tolerate other medications. So one issue is of tolerability, second issue is of compliance. So if they are feeling too bad with the steroid dose, so we usually prescribe antacids. And even with the ATT, we prescribe antacids, and the molecule Rizorine has an advantage that it causes less acidity. So acidity is a common day-to-day problem, and we want our medicines or prescription to be honored and compliant by the patient. So as a chest physician, when do we give more than normal importance to the acidic symptoms? If we find that despite of appropriate medication, dosing and compliance, patient is having uncontrolled asthma. If they still says that we have symptoms during the night, we have to take the rescue medication more than twice a week, and as per our assessment, the patient is all right during the day, or patient complains mainly symptoms after having a heavy meal, we give more than normal importance to the GRD symptoms and try to control it in a more stricter way. Second group of people are who are steroid resistant or steroid dependent. So practically they are on some doses of steroid most of the time of the year. So that subset, which constitute about 5 to 10% of patients of asthma, are usually on some doses of steroid during most of the days of the year. And probably these are the patients for the advanced form of treatment like bronchial thermoplasty and other things which we are doing on selecting subset. And they have the clear-cut symptoms like heartburn, and which is they can have a heart brash or heartburn, or the typical symptoms the patient give us. They have hoarseness of voice. They have predominance of nocturnal crisis. They are usually symptomatic after going to sleep after a heavy meal. They have cough or wheezing after a large meal. And asthma symptoms worsen after certain foods such as chocolate, alcohol, peppermint, coffee, etc. And asthma symptoms are vomiting or some episode where aspiration could have happened. So these subset of patients, if these symptoms are too prominent, then probably GRD has to be taken in consideration, and a stricter GRD management has to be put into place. Otherwise, SOS, pantoprazole, or the usual kind of instruction we wish to give to our patients are good enough even in asthmatics. What are the extra esophageal manifestation of GERD? So it's not only the asthma we are talking because we have literature support on asthma, but sometimes the patient comes with very vague complaints, and as a specialist, we are the one who have to bear them. They have been through many generalists, they have to be many physicians, they have through many gastroenterologists, and they try all doctors because their symptoms are very vague. And at times these people are labeled as having functional symptoms, or because we are unable to find a cause for them. And many of them has a non-cardiac chest pain. So in my OPD, I used to do, the present hospital is doesn't run a free OPD, but the earlier hospital used to have a free OPD. So my protocol with patients, especially females coming with a vague chest pain, the three things which I always consider: rule out a pulmonary pathology by doing an X-ray chest, talk about their eating habits, because most of them, females in our Indian setup, feel pride in skipping their breakfast and taking minimum amount of meal. I don't know, they idealize Nirupa Rai too much. Probably Indian movie that mother shouldn't eat and should sacrifice their meals for the family. So they are the true follower of Nirupa Rai. So after ruling out any organic pathology in the chest, I would like to know about their eating habits. And third thing which I would like to do is the vitamin D levels. So lots of them have vitamin D deficiency. So most of the time, non-cardiac chest pain has these three reasons. First, we rule out a retrosternal lymph node or a tumor or a mass by doing an X-ray or CT if required. And then we go for all these things, and sometimes simple prescribing of antacid helps them. Chest discomfort, which is a very vague term for anybody and everybody, and investigation can list from nothing to CT pulmonary angiography, because sometimes if the patient is too much symptomatic, you cannot rule out a pulmonary embolism. So even sometimes you have to get a CT pulmonary angio, and even if comes out to be normal, you take a sigh of relief. Oh, it's only acidity. Abdominal pain, coughing. So chronic cough, any cough which is more than 8 weeks, GRD can be the culprit. So while taking a detailed history with the patients of chronic cough, we must not ignore the symptom of GRD, the eating habits, the food items which are being consumed. Some throat irritation. Some people always complain of pain in the throat and hoarseness of voice. And sometimes the GRD can be responsible for postnasal drip as well, though very rarely we see that. So these are very vague symptoms where GRD could be the culprit, and simply taking care of the eating habits and some medication can help the patient. So these are the other manifestations, we have talked about it. And this is the thing which talk about the prevalence of GRD. It's with various things. Asthma we have talked, laryngitis almost 42%, hoarseness in 38 to 70%, chronic cough. This is a very important subset because I have treated many of the chronic coughs by simply taking a detailed history and finding out the culprits. At times it could be thyroiditis, at times it could be GRD, at times it could be eosinophilia not treated well, at times it can be cough variant asthma. So it's a tricky subset of people with chronic cough. So people come to us with 12-year cough, 20-year cough, and we have to find a reason. Sometimes it's a bronchiectasis due to the childhood pneumonia or tuberculosis. So this subset is really tricky. And sleep apnea has a altogether different pathology. I would not like to dwell into it because it will be in great detail. So we have talked about the reflux theory, direct contact between gastric acid refluxate and lung tissue. And I think it's the repetition of the older thing. I will not repeat it. And what's the solution? All of us know, take your medication, elevation of head body. All of us are doctors. I think all of us know, and I would not like to, go into it. Role of proton pump inhibitor, probably Dr. Jain would be covering on it, and I would not like to take much of the time. But usually, yes, prescribing therapy for 2 months, for 8 weeks to 12 weeks, usually help the patients. So we have studies, we have evidence in the literature, and we have talked about it. Yes, there is a relationship between GRD and asthma. So the message which I would like to convey that if your asthma is not getting better, if your asthmatic patients are on some doses of steroid, please add proton pump inhibitors to the regimen. So these are the studies which show the benefit of treating GRD in patients with asthma, and now the GINA guidelines also emphasize on better control of acidity symptoms. And now another disease entity, which is the idiopathic pulmonary fibrosis. And this paper is from Mayo Clinic, and Dr. Ganesh Raghu is a world expert on ILD, interstitial lung diseases, and there is an association. Though the association is multifactorial, acidity is not the only thing which causes interstitial lung disease, but yes, it is one of the cofactors or one of the reason for causing interstitial lung disease. And as I said, so for asthma, our patients are on steroids only for a short duration of time, but ILD patients are on some doses of steroids throughout their life. And though the steroids alone are not the mainstay of treatment, but steroids are there to help them symptomatically. So such patients need to be on proton pump inhibitors if they have very severe symptoms or some symptoms. The precise relationship between chronic microaspiration and idiopathic pulmonary fibrosis remains unknown. But yes, there is a relationship, but is it the only thing which causes? It's not the case. And the chronic cough, we have talked about it, 10 to 40% of people, GERD is the reason, and it has an epidemiological association. Usually patients give history of nocturnal reflux. pH impedance monitoring studies give most convincing diagnosis. I'm sorry for the spelling mistake. All cough manifestation associated with pH of less than 4. A 4-hour esophageal pH testing in the diagnostic armamentarium, GERD can account for chronic cough in up to 40% of patients. So esophageal pH testing is the most sensitive test to associate cough with GERD. So in which patient of chronic cough in whom GERD should be investigated? More than 8 weeks, patients who we should take a history of ACE inhibitors if that is absent, not a present smoker or exposed to other environmental irritants, chest radiograph is normal and symptomatic asthma or a cough variant asthma has been ruled out, and we have ruled out postnasal drip or sinusitis by doing a CT paranasal sinuses. And I think I would like to stop here. I think it's Dr. Jain's turn. I would not like to talk about asthma. Let's stick to the topic. And the take-home message. GERD is a common cause of chronic cough, around 40% cases. Remember adding antacids in such cases. Asthmatics should be assessed for GERD symptoms and managed with proton pump inhibitors if still uncontrolled. Acid reflux as a cofactor for developing ILD is well established. Other GERD-related upper and lower respiratory symptoms should be kept in mind and treated accordingly. Thank you for a very patient hearing.